Okay, welcome everyone to the Health Research from Home webinar. This is our 12th webinar, and I'm really delighted to welcome two excellent speakers today. My name is Will Dixon. I'm the lead investigator for the Health Research from Home network, and together with me, I'm co-hosted with Coral, our project administrator. So this is what you've joined us for today. We've got some housekeeping to begin with, and then two talks from Jake Sunshine and Ela Gruzewska about advancing cardiovascular monitoring from radar sensing to wearable emergency detection. We're going to have a Q&A section. We might be able to extend a little bit beyond 10 minutes actually today. And then we've got a short driver project update about how we're working to link patient-generated data to other data sources. We'll talk a little bit about the Paprika study in knee replacement and finish the webinar with some brief announcements at the end. So for the housekeeping, we're recording today's webinar. The recording will be uploaded to the YouTube channel next week. We're going to edit out the Q&A from that recording, but you'll be able to find a link to the YouTube channel in the webinar follow-up email. Through the talks, we really encourage you all to submit questions via the Q&A box in the Teams. You can submit a question for the Q&A at any time, and then we'll come to the questions at the end of the two presentations. Everyone's microphone's been muted for the presentation, but we will be able to unmute anyone who's keen to ask a live question at the end in the Q&A. And feel free to use the chat box to interact with one another through the course of the webinar or to ask us for any technical support if needed. So a real pleasure to introduce the two speakers. Jake Sunshine. Jake's an associate professor and a research scientist at both the University of Washington and at Google. And Ela is a senior software engineer at Google. So I'm going to stop talking and hand straight over to Jake. And I think we're in for a treat.
Perfect. Okay. Hi, everyone. Really nice to be here. I'm in Seattle, Washington at 7 a.m. here. I'm hoping my kids don't barge in. I'm going to be talking about building intelligent systems today to detect cardiopulmonary emergency. I'm an associate professor and physician scientist at the University of Washington. And then I also lead a research group at Google. Next slide, please. So by way of disclosures, on the top line are agencies that have funded my work at the University of Washington, and then I have an employment relationship to disclose as I'm an FTE at Google as well. Next slide. So as a brief outline, I'm going to start with sort of a motivation for the work that I do. I'll talk a little bit about the sensing surfaces of interest, which sort of span different commodity devices from smartphone and smart speakers to wearable devices. The approaches that my group employs involving audio and optical-based sensing. And then I'm going to highlight just two studies, one that's sort of proof of principle, and then one translational study involving wearable devices that involves a system that's out in the world today, including in the UK. And then hopefully we'll have a little bit of time for questions. Next slide, please. So, and you can just keep on going, Coral, just open this up. So a lot of people ask me why I think about smart devices, why I spend time as a physician thinking about things that are, commoditized, not necessarily used in a healthcare setting. So I like to start at the far left there, looking at a device called a Philips X2 monitor. I'm a anesthesiologist by training. This is a device that we use in the operating room. This is something that's used in an intensive care unit. It's something that can do vital sensing and monitoring of vital signs. And as you can see, sort of its technical specifications and its cost, this is a device that you can really sort of keep somebody alive with. However, its technical specifications are actually quite pedestrian compared to these devices that are up here that are now, probably a couple of years old. And so the devices that we sort of carry around in our pockets, that we might be wearing on our wrists, that might be lying around in our homes, are actually quite capable as far as what they can do compared to devices that we use to keep somebody alive in an operating room, in an intensive care unit. So if you kind of shift how you think about these wearable devices, think that they might just be used for wellness or things like that, but think about what it might mean if you can use these devices for ICU level monitoring in the world. It sort of opens up this possibility of different applications you can think about, especially if at sort of public health scale. Next slide, please. The other, important part about these devices that's probably very self-evident is that these can scale, they can use software only, and so you can have much greater impact than sort of these physical devices that we use in the hospital. Here's just a couple of papers that are sort of over the years. Lots of these are sort of proof of principle, demonstrating that just about all of the capabilities that can be done on that device have been demonstrated in using some form factor or another on sort of commoditized wearable devices or smart devices that are in our home and in our pockets. Next slide, please. So I'm going to talk first off about work that I've done related to using this for the application of breathing. I'm not going to dive too deeply into this. Ela's probably going to talk about FMCW as it relates to radio waveforms, but you can use these devices for sensing in a contactless manner using active sonar. So all of these devices, they have embedded speakers, they have embedded microphones. You can emit high frequency tones with these devices. Those will reflect off of the environment, and that will be associated with different frequency changes. And if you can think about something related to, wearable devices, I'm sorry, not wearable devices, but devices that are sort of in our homes, they might bounce off of a potted plant, a coffee cup. However, there's probably going to only be something in the environment that has the exact frequency related to chest motion, related to breathing. And so we're able to tease out breathing from the reflections of those sound waves in the environment. And it's important to say this is not like listening, as we would think, like it's listening for the sound of breathing. It's using things in inaudible ranges to measure chest motion. And so if you think about sort of what you can do if you can measure breathing, there's actually several applications. Next slide, please. And you can just keep on clicking through until you see this. So there are a couple of things. First, in sort of the wellness category, what you can do is you can measure people's sleep if you can measure breathing. There's very strong associations with different sleep stages based on respiratory patterns. You can also measure the presence of sleep apnea. There's been some papers demonstrating that. And then you can use it for sort of an indicator of when people might be breathing quickly, if you have sort of an advanced infection. And then also for chronic disease management, measuring if someone is well controlled in their COPD management and seeing if they're tipped over. However, the thing that was sort of most interesting to me, this is now probably in 2017, 2018, was a huge problem in the United States and worldwide is when people experience unanticipated acute respiratory failure that arises from potent opioids. And so our initial questions had to do, well, can we measure breathing associated with overdoses? And I'm going to talk about how we built sort of a proof of principle algorithm for just that, using something that can be deployed on virtually any smartphone. Next slide, please. And you can advance, thanks. So you can imagine, you want to go back, building an algorithm for this purpose is actually pretty challenging. It can't just, again, sign up graduate students, have them, necessarily sort of like simulate an overdose. You can't really do that. However, in the operating room, you may or may not be aware of this, but we give fentanyl all the time in an indicated manner where it's allowed. We give other drugs as well that can sort of potently depress respiration. And so this is, standard part of most operating room procedures. And so we got permission to sort of take advantage of this fact that people will be experiencing this sort of overdose-like breathing in the operating room and use various measurement equipment to sort of see if you could measure someone making that transition from sort of normal tidal breathing into sort of a persistent apnea. And we, had permission. These were people who were previously scheduled for their surgeries. They were all quite healthy. And then we were able to leave them persistently apneic for about 30 seconds. That may sound dangerous, but it's not too dangerous when we pre-oxygenate people before that procedure. The other place where we collected data, I'm in Seattle. It's about 2.5 hours south of Vancouver, British Columbia, where they happen to have a supervised injection facility. I'm not sure if these exist yet in the UK. They've been in Canada for a couple of decades now as sort of a harm reduction way for people to use these drugs in sort of a medically supervised manner. And so we were also able to collect data there. So I'm going to give sort of a high-level overview of what that looked like. Next slide. The first is sort of the operating room environment. We've got someone who is sort of in their gown, and then we've got lots of different equipment that's monitoring them. That first one is using active sonar on the phone. We also have a radar module that's on that Mayo stand as well. And then it's harder to see, but around their chest, they've got sort of a respiratory impedance monitor serving as sort of a ground truth. And then we've got the anesthesiologist there who's going to give a drug called propofol, which in combination with fentanyl will cause someone virtually every single time to stop breathing. And so then you can also see that oxygen mask that's on their face. A little aside, when there's usually lots of people in an operating room, if you get too close to these devices, it can measure your breathing. So everyone sort of had to step away from the patient after we pushed the drugs to make sure that we weren't getting readings from other people in the room other than the patient. And then if you want to advance one more, it's going to show what it looks like in this supervised injection facility. And so this is the rockstar graduate student who led a lot of this work. You can see this is a stall. There's about 12 stalls in these places. You can see through the mirror. There's sort of a place, basically a nursing station of people looking sort of they don't continuously measure vital signs there. It's all based on sort of initial observation and to see how people are doing. And then people they bring their drugs in. We did a verbal informed consent for this, given the nature of what we were measuring. And then people would sort of prepare their drugs. Excuse me. People would prepare their drugs and then self-inject, and we would monitor for their breathing for about 1 minute before and then about 5 minutes after. So if you want to advance the slide. Just it's sort of, yep, and just keep on going there. We had about 209 users. 115 people were used to sort of develop what this algorithm looked like, and then about 94 to test it. At the time, we asked people to share what they were using. If you looked at statistics from Vancouver, BC, about 98% of the drug supply contained fentanyl. So even people who are saying they're using heroin, it almost certainly had fentanyl in it. And then so the outcome frequency was pretty frequent. So lots of people had bradypnea or respiratory rate less than 7. And then about 48 people had apnea events. And so what we found was this was, the smartphone was actually pretty good at measuring people's respiration. And if you want to just keep on advancing, it'll show sort of what we had for sort of sensitivity, and that for sort of the primary outcome of respiratory rate of less than 7. And you can see sort of a decent sensitivity and specificity listed there. So if you want to just advance just one, this was published in Science Translational Medicine. It was led by Rajalakshmi Nandakumar, who was the graduate student, and now she is on faculty at Cornell Tech in New York City. So heroic work on her part to get this data collected in a really, really sort of challenging environment for data collection, but she did an amazing job. So I just want to make sure that she's recognized there. Next slide, please. So here's a demonstration. This is sort of a smart speaker that's sort of built in the lab. Hopefully you can appreciate this. It's sort of sitting on a bedside table, and then you can see sort of a sinusoidal pattern of those frequency changes from the FMCW sonar as the chest gets closer and farther away. So it's just something to think about. It's a pretty non-invasive way to measure respiration. And like I mentioned before, it sort of opens up this this world of possibilities of what you can do. And here in this situation, this could be a great way for sort of wellness applications of measuring sleep. Next slide, please. So this, we had a spin-out company that built this into a first of its kind respiratory monitor. This is sort of a spot check respiratory monitor, but I'm happy to answer sort of any questions because I know there's a lot of academic folks here about sort of making that step from, discovery into a lab, to spin out company to getting something approved by a regulatory body. Next slide, please. And so what about other conditions? So this was a really sort of exciting application. And so things that we thought about were things that also kind of had this element of being sort of a time-sensitive emergency that were sort of at public health scale. Things that, like overdose, have sort of an effective evidence-based intervention if they're initiated rapidly, and then can affect people sort of across an age spectrum. And what we landed on was the clinical entity of out-of-hospital cardiac arrest, which I want to talk about now. If you want to go to the next slide, I'm going to focus this on the wearable device, which was developed at Google. So now sort of putting on my Google hat. And so what makes unwitnessed cardiac arrest a unique opportunity for passive sensing is something I want to talk about on the watch. I want to talk about why passive sensing on a watch is really, really challenging. I'll give a high-level description of the watch system, and then sort of considerations from going from 0 to 1, like basically an idea to deploying something that's used all over the world. Next slide, please. Yeah, so building something that's a regulated device requires a lot of people. It's really incredible, all the different inputs and stakeholders that are required to just like launch something. And so huge team acknowledgement for helping build this, and everything I'm going to talk about next is really due to the contributions of a very, very large and talented team. So next slide. Also very important when we talk about cardiac arrest versus heart attack. I don't know the makeup of the entire audience. Cardiac arrest is not a heart attack. When we talk about heart attack, usually we're talking about sort of a circulatory problem or a blocked artery. Not always, it's usually more complex than that. But we're talking about, the canonical signs relate to sort of chest pain, shortness of breath. People can still talk to you. When we're talking about cardiac arrest, we're usually talking about an electrical problem. The heart cannot beat, therefore people are unconscious, they are not responsive, they are completely reliant on other individuals to help resuscitate them. Don't get me wrong, heart attack is an emergency. Please go see a doctor if you're having a heart attack. However, cardiac arrest is literally the biggest emergency that we have. It's extremely time sensitive. And that leads into the next slide. Which is, I think, something that's really important to appreciate about how unique cardiac arrest is compared to sort of other clinical entities. So like I said, it's probably one of our biggest time-sensitive emergencies, and it also has this sort of tremendous societal infrastructure in place for sort of timely identification and resuscitation. And so I like to highlight this is interestingly like sort of one of the only clinical entities where you don't need to be a nurse or a doctor to be trained for this. You can take a CPR class and we'll train lay people to be able to recognize this event, and not only recognize it, but then what the next steps are to even treat it. In Germany, I believe you can't get a driver's license without learning CPR. In Asia, in some countries, it's a mandatory part of the secondary school curricula. And then, like I mentioned, there's also this tremendous physical infrastructure, public access, defibrillators, all these things we do and make tremendous investments sort of as societies to minimize the time from when someone collapses to when they can get resuscitation. And so we don't really do that for most other things. And it's really incredible that we do that. And that makes this problem a lot more tractable for using wearable devices to help identify them. Next slide, please. Yet for sort of all of this infrastructure that we have in place for these emergencies, we know that about 50% of the time, some estimates are as far high as 75% of the time, there's no one around. So this whole framework rests on the idea that someone, usually a human, will be there to identify your cardiac arrest and make a call on your behalf to activate these links in the chain of survival. But we know that that's not the case a large fraction of the time. And so our question was, could we use a commodity device like a watch that's fairly ubiquitous to help serve as sort of that witness? Next slide, please. You might need to click a few times. Keep on going, please. So this is sort of a whole talk unto itself, but I just want to say a couple of words about why this is so hard to do. First, it has to do with sort of the signal quality of the PPG signal. These devices that are sort of on our wrist, you're firing photons into the top of the wrist and then looking for the reflections of just a small subset of photons to help measure someone's arterial expansion to measure their heart rate. The difference between that and sort of a traditional pulse oximeter that's also measuring PPG, we're talking about something that might have about 1/10 the signal quality compared to sort of clinical equipment. And then there's sort of the challenges of prospective collection of data for research and development purposes. Similar to the opioid instance I gave, it's hard to just get a cohort of, first off, you can't just get people who to have a cardiac arrest for you in the lab, and you can't do that. That's not ethical. It's also a rare enough event that assembling a cohort and following them prospectively and waiting for events is also challenging. And it's also challenging because if you would want to have sort of continuous raw data logging for that period, and as people are probably aware of, that is going to have high battery utilization for whatever piece of equipment that you're using. So it's hard to assemble a cohort waiting for a long time and then expecting people to sort of recharge or change their device like every 8 hours or 10 hours or something like that. So there's just these sort of real constraints around running a huge prospective study involving raw data collection. And then we're talking about a very consequential classification. So if something is tied to sort of a 911 system or an emergency response system, it's a public resource that we all rely on. And so everything needs to be done to sort of minimize false positives. And so sort of like cumulatively, that makes getting this right really, really hard. It's easy to do it in a wrong way, but it's really, really hard to do it in sort of a socially responsible way that's going to be deployed at scale. Next slide. And so the goal here is really to convert unwitnessed events into functionally witnessed events. And this is sort of the epidemiology slide that I hope underscores sort of what a big opportunity here this is. So overall, there's about 5 million people worldwide who experience a cardiac arrest. I mentioned before, about half of those people are unwitnessed. If you look at about a further half of that unwitnessed segment, about half of those have no resuscitation attempted at all because they're simply found too late. We're talking about people who are discovered basically deceased where resuscitation is deemed futile. And so if you go to the next slide, I'm going to give some examples of what this looks like in Seattle-King County, where I live, that happens to have some of the best resuscitation outcomes in the world due to a lot of research and quality improvement within the resuscitation infrastructure here. So here in Seattle, if you have a witnessed cardiac arrest, your chance of survival are about 20%. Unwitnessed, it's about 4%. That's probably an overestimate. However, sort of conceptually, if you were to look at sort of witness status as an intervention, as sort of a thought experiment, you're looking at something that has about a 16% absolute risk difference. And so for people who are familiar with sort of the concept of sort of a number needed to treat, that's about 1 in 6 to save one life. And that's extremely favorable from a public health benefit profile, especially if you can minimize sort of the downsides of that intervention. In this case, excessive calls to 911, false positives, et cetera. And then if you just want to hit advance, it's going to show just a couple of examples of sort of numbers needed to treat for some pretty rock solid interventions that are known in the cardiology literature. For people getting coronary artery bypass, it's about 1 in 25 to save one life. For aspirin in people experiencing a heart attack, it's about 1 in 42. And real quick, Coral, how are we doing on time?
We're just about coming to the end of the time, but
okay,
please carry on for now.
Yeah, let's advance forward. And I'll tell you, and so I'm going to have you advance, go to, keep going, keep going. We'll go here, and then we'll go straight to the results. If you want to go back one. So I mentioned all of the challenges of building a device for this purpose. And so we started by looking at data sets that were publicly available that did happen to capture people who experienced out-of-hospital cardiac arrest, in this case, using a Holter monitor. And what we found was a lot of people experiencing these events made sort of a sudden transition from sort of a pulsatile rhythm to a pulseless rhythm, looking at the far left. Looking over one box, that PPG from arterial occlusion, we went to the lab and said, what can we do to look at, to basically reproduce this sort of sudden transition from sort of a pulsatile state to a pulseless state? And sort of not surprising to people who are familiar with these signals is you're able to sort of recapitulate that signal suddenly using a sort of specialized tourniquet that we use in the operating room that can sort of instantly make somebody pulseless in their periphery. That in and of itself is not sufficient. You couldn't just sort of go to a regulatory agency and say, this represents cardiac arrest. And so sort of the key thing that we did was we also went to an electrophysiology lab where people had implanted previous defibrillators, and we're getting those devices tested. And so actually what that involves is a proceduralist under the supervision of a specialized cardiologist as well as an anesthesiologist, having people have their hearts stopped to test if their implanted defibrillator fires appropriately. And so what we found was that signal looks very similar if you have a central reason for the heart stopping versus if you have a peripheral version of the heart stopping, which we can mimic with that specialized tourniquet. And then also we had stunt actors that were a part of this, because commonly, like I mentioned, this is not associated with perfusing your brain. And so frequently people will have these sort of very dramatic unbraced falls when they experience these events. So we can just go fast forward, and I'm going to talk about what we did to, we'll go through this and keep on going. Very briefly, this algorithm is designed with multiple gates that sort of need to be passed through before a classification is made. That's the only way that you can do this responsibly and keep false positives down in a way that is not going to lead to excessive phone calls. And so basically with this multi-gate algorithm, we had to test it prospectively in a large cohort to ensure that it had adequate performance across different body types and different skin colors, and also different profiles of perfusion. And so the results of those are going to be shared on the next slide. Go one more slide. And so what we found testing this sort of multi-gate algorithm was that this led to about one unintentional emergency call every 21.67 user years across 2 prospective studies. So people wearing the device, having the algorithm running all of the time. And then there was only one unintentional emergency call that someone progressed all the way through the complete algorithm. The sensitivity of this device using the sort of arterial occlusion cardiac arrest sort of simulation model that I alluded to in the previous slide had a sensitivity of about 67%. And so you might be wondering, oh, well, that's kind of low. Well, we are optimizing, at least initially, for making sure that false positives are in check. And so that required being very, very thoughtful about what our sensitivity performance could look like. And then if you want to just go to the last slide here, this was published in Nature in February of 25. There should be a link, hopefully in the notes, to this paper, which you can read more about it. And with that, I will stop. And if you have any questions, my email, both my UW email and my Google email should be available. So thanks so much.
Great, thank you, Jake. So if people have questions for Jake, please stick them in the chat. But we'll hand straight over to Ela to hear about radar as a method for detecting heart and respiratory signals. Thanks.
Thank you so much. Can you confirm you can see my screen well?
Yeah, we can see that. Thanks, Ela.
Great, thank you. So thank you and thank you. Hello, everyone, and I'm really pleased to be here. I will be talking about our research on UWB radar-based heart rate monitoring. So let's first start with the motivation. Heart rate is a critical physiological parameter, and heart rate monitoring is really valuable for a wide range of both healthcare applications, like continuous monitoring for hospitalized patients, spot checks for at-home care, telemedicine, but also for some wellness applications like exercise and fitness tracking, sleep analysis, and hydration assessment. And when we think about the heart rate monitoring, the first consumer device that comes up to our mind are smartwatches, which do provide a continuous and precise heart rate monitoring. However, their adoption lags far behind smartphones, for instance. And what's more crucial is that around 40% of smartwatch owners don't report not wearing them all the time due to the discomfort or the need of battery charging. So when we think of another alternative consumer devices that could potentially be used for the heart rate monitoring, another option could be the Google Nest Hub, which does provide the sleep sensing using the SOLI radar. However, it does not directly track heart rate, and also it's not quite as widely adopted. So in this research, we were trying to understand whether actually the smartphone device can be used for heart rate tracking. And obviously, it's very widely adopted. Almost everyone has a smartphone now. And these days, modern smartphone devices do also come with the UWB technology built in. Currently, in most cases, it's only enabled in the ranging mode, and it's used for features like localization and tracking. So AirTags and smart tags do use UWB technology underneath, and also for like vehicle unlock features or data transfer. But what we wanted to assess was whether the same radar technology with the radar mode enabled could actually be used for heart rate tracking. As Jake already mentioned, the radar technology can be used for vital signs monitoring by tracking the micro motions of the body, usually of the chest wall. So you can see both like bigger motions related to respiratory, but also you can see those like very, very small micro motions related to the heartbeats. And also the radar technology preserves privacy, is agnostic to the skin tone, and penetrates clothes and blankets, and is independent of lighting condition, which means it could also be used for the sleep tracking. However, one of the biggest challenges here is that most models these days are designed for the lab-grade equipment and not the sensors that are actually available in the consumer devices. And moreover, the algorithms are often sensor-specific, requiring extensive retraining for every new hardware. And just to highlight why the latter is problematic, I would like to show two examples of two radar technologies which are most frequently used in the consumer devices. The first one is frequency-modulated continuous-wave, that Jake touched on before, which works by transmitting chirps, which is continuous sinusoidal wave whose frequency increases linearly with time. And here, if you want to measure the distance of the given object, we actually compare the frequency between the transmitted and received signal. On the other hand, impulse radio ultra-wideband, so UWB radars, work by transmitting very short radio waves. And the distance here is measured by the time it takes for that signal to travel to the object and back. So those two different radar systems operate in completely different physical principles. Moreover, different radar technologies can have different number of transmitting and receiving antennas, or different frequencies and bandwidths and range resolution, which makes it really difficult to transfer algorithms between different radar systems. The goal of our research was to achieve the clinically acceptable accuracy for heart rate monitoring on the consumer-grade UWB radar. And we had an access to two data sets. The first one was collected using FMCW radar. More specifically, it was using the SOLI radar built into the Nest Hub device. And it was really comprehensive big data set with over 900 hours recording, where a participant spent the whole night in the sleep studio. So we had around 8 hours recording per person. And they actually slept in the bed with the Nest Hub device on the bedside table. They also had the ECG sensor for tracking the reference heart rate. And on the other hand, we had an order of magnitude smaller UWB data set, which was collected using the UWB radar fixed on the evaluation board. And that data collection was done in a partnership with University of Sheffield. And there were only 21 hours of recording, so like around 6 minutes per person. And we also had ECG and PPG sensors there. And not only the different radar technologies were used to collect those two data sets, they also had a very different configuration, so different number of receiving antennas and also different range resolution. However, what we wanted to assess was whether we could actually leverage that large label data set from a different radar modality to improve the performance on the UWB radar. And this is a concept commonly known as transfer learning, where we try to learn some features from one task and actually boost the performance on another task. This is quite frequently used in the computer vision, where we, for instance, pre-train the deep learning model using the ImageNet dataset and then fine-tune it using some other very specific dataset. So we wanted to assess whether the similar concept actually can also be applied to different radar modalities. So what we did was first to try to estimate the heart rate from the FMCW radar signal. We built a system which consisted of two parts. First one was the signal preprocessing, where we did some filtering of the signal, then the presence detection and the features extractions from the signal. And then that followed with the deep neural network model. We actually proposed the novel model architecture, which combined two-dimensional ResNet and one-dimensional ResNet to be able to extract the spatial templar features from the radar signal. And by doing this, we actually received the state-of-the-art results on this data set with under 1 bit per minute MAE. Then the next step was trying to also achieve the good performance on UWB radar. So first, we took that large data set of FMCW radar. We did some data preprocessing so that that data set better resembles our target data set. So in particular, we lowered the resolution of the data. And then we once again trained that novel neural network to the M1 ResNet model. And then as a second step, we take our target data set, UWB, and then we fine-tune that model. And then we showed that by doing this, we actually improved the performance of our model by 25% compared to the baseline model, which was only trained on UWB dataset. And more crucially, we also met our target MAE below 5 bits per minute, which is clinically acceptable. In the conclusion, I just want to mention that there are some limitations to this research. First of all, the UWB dataset was collected using the radar fixed onto the evaluation board rather than from the actual smartphones. So more data collection, more research needs to be done to be able to assess whether that actually works also from the smartphone devices. And also that dataset was collected in a very well-controlled environment with just one person in the room without the movements. So again, more work needs to be done to evaluate that on the more noisy environment. Nevertheless, we demonstrated that the transfer learning between two consumer-grade radar modalities with completely different physical principles is possible, and that could potentially accelerate the development of heart rate monitoring algorithms and its introduction into the consumer devices. And finally, we also achieved clinically acceptable accuracy on the UWB radar, which can be found in the mobile phone devices. I would also like to acknowledge that this research was possible because of the collaboration of not only two different departments within Google, but also the collaboration of our external partners from University of Sheffield. So thank you to everyone who contributed to this work. Thank you.
Thank you so much, Ela, and thank you again, Jake. Really wonderful, wonderful talks, really very exciting work. So we're just going to conclude the webinar with a few small additional bits So in health research from home, we believe that the UK is a potential world leader in the use of smartphones and wearables for health research. And that's partly because of the fantastic health data assets that we have in the UK. We have universal access to healthcare, cradle to grave records, and a really good infrastructure to make that data available for research. But the data from smartphones and wearables tends to sit separately from the health data. And so within the research program, we have a couple of driver projects that are interested in learning how we can join these two data sources together. One of those is led from Manchester called Paprika, which is about physical activity patterns after knee arthroplasty. You've been hearing through the webinar series how we've progressed in the setup of this study. And just around Christmas, we went live with this study and it's now open to recruitment. So we thought we'd show you a short video about the study and then seek your help and ask you to spread the word and help us recruit the participants that we need. So here's a short video, which I hope will work. Let me know if you can't hear the sound.
Arthritis of the knee affects over 1 in 5 people aged 50 and above. It's a painful disease that can severely reduce mobility and worsen quality of life. Knee replacement surgery is a life-changing option for some, improving pain and activity.
It's painful for me to go up and down a flight of stairs, particularly down, and I don't seem to be able to get across the road quickly enough if I need to. How much will my mobility improve after surgery?
Did you know that the data from your smartphone or wearable device could help to answer questions like this?
Hello, my name's Will Dixon. I'm a professor at the University of Manchester and a hospital doctor looking after people with arthritis. At the university, I work as an epidemiologist, studying diseases like arthritis and their treatments in populations. In the UK, the National Joint Register holds knee surgery information for everyone who's had an operation in the last 20 years. This is available to researchers like me, but the register doesn't collect information on physical activity, so we cannot work out how much better people's activity gets using that data alone. However, many people who have already had a knee replacement owned a smartphone or fitness tracker at the time of their surgery, which will have tracked their step count before and after.
Our research team will connect your personal data with the National Joint Register so we can tell future knee replacement surgery patients how much mobility they will get back after surgery.
If you join this study, you'll be helping me and the other 100,000 people who undergo knee replacement surgery in the UK every year. Please join this study today.
So if you know of somebody who's had a joint replacement, we're really keen that they would take part in our study and help us work out how to run studies such as this. So if you share the link with them, they will go to a study website where they can learn more about the study. They can watch that video. And then once they've gone through the patient information sheet and the consent form, they then step through 3 essential tasks and 1 optional task. The 3 essential ones are finding out short information about their joint replacement, sharing some information, their NHS number that allows us to link their data to the right health record, and then thirdly, giving us permission to access their data. So for Fitbits and Oura Rings, they just log on to their account and we can then pull the data via an API. If they have Apple devices, an iPhone or an Apple Watch, they need to download an app that shakes hands with the device and then it releases the data to the research team. If you need to encourage people to take part beyond simple altruism, they can get entered into a prize draw for a very small Amazon gift voucher, but that might be an additional motivation. So if you do know of people in friends and family and you think that they might be able to take part, please let them know. All of this information will be on the YouTube channel, so you'll be able to pick it up. But essentially, we're looking for people who've had a knee replacement in the UK between 2017 and 2023, from January 17 to December 23, and they had to use one of those 4 different devices. Really grateful for your help if you can. The next thing to talk about is an advert for our Connect event. This is our annual event for health research from home. Unfortunately, the in-person tickets sold out within 24 hours, but we, with the help of colleagues at Google, where it's hosted, they're going to live stream this day-long event, and you can sign up now for online tickets. So if you don't already have an in-person ticket, please scan the QR code and you can sign up for an online ticket and live stream on the day. This is the agenda for the day. We're getting a view of what it's like to live with a long-term condition and how public contributors have usefully informed health research at the start of the conference. We're then going to get a view from government, hearing about digital in the NHS 10-year plan from Felix Greaves. We've got 2 keynote talks at either end of the day, one from Josh Denny, who's the CEO of the US All of Us research program, who've got over 500,000 people recruited and who've got a wide program of research using Fitbits, and Fiona Ball, who's the head of physical activity unit at the World Health Organization. There's a session on a technology showcase where we're hearing about how you might make best use of the technology within the phone, not dissimilar to today's webinar actually, but we're learning about specifically making use of the global positioning system, then making use of the touchscreens through cognitive function tests, and making use of the camera and audio. And finally, there's a research showcase, 10 early career researchers giving a 3-minute pitch each about their work using smartphones and wearables for the Ken Rothman Award, a very fine trophy to take away with you if you're the winner. So please do sign up if you're interested. You can see historical health research from home webinars on our YouTube channel, and today's one will be up there, minus the Q&A session, probably within the next week or so. Final slide is on some resources that you can get from the program. There's a GitHub, the program website, at LinkedIn. You can sign up to the regular newsletters. And that's it for today. We're going to end with a poll to see if you have suggestions for further speakers for the final year of the program. If you have good ideas, we'll do our best to see if we can invite those people along. But that's it for today. Thanks again to Jake. Thank you, Ella. Thank you all for coming along, and we hope to see you again next time in a couple of months, or maybe even sooner at the annual event. Thank you. Goodbye.